let's talk about large cell lymphoma. You know, there's data recently presented, the Scholar-1 study, Michael Crump, looking at basically a retrospective analysis of multiple different clinical trials and the expected outcome for patients that have refractory large cell lymphoma. And that's pretty dismal, right? There's 20 to 30% response rate. You know, the median survival is 6 months or 6 months or less. And so there's clearly a need for new drugs in that arena. One place that PD-1 inhibitors have been tried are in the post-autologous stem cell transplant space. So pidilizumab, there's a study with that was published a number of years ago trying to use the drug there. Krishna, what's your take on that? Do you think that's a good idea?
Yeah, so it's an interesting concept because so Philippe Armand did a study that was published in the JCO in 2013 using pidilizumab, giving 3 doses of it after autologous transplantation. And after autologous transplant, there are a number of, I think, very interesting things relevant to how immunotherapy may work and where it may best work. First is you've just had the patients get high doses of cytotoxic chemotherapy so that the disease burden has gone from often modest to high in these patients who had always relapsed, and of course were often getting salvage therapy. Most of those patients had measurable disease at the time of transplant. So first, their disease burden had been reduced so to the point where, again, an immune response could perhaps finish off the malignancy. The second thing is we know that the post-auto transplant period, in terms of how the immune system is, and this is what been a focus of my lab in both the auto and the allo transplant setting, we know that there's lymphopenia, so that if you can expand an antigen-specific immune response against the tumor, that it may have a relative advantage in terms of outcompeting other cells that would normally be, competing for cytokines and other things that drive the growth of T cells. And the third thing is that we know that in that post-transplant setting, that lymphopenia-induced expansion of T cells tends to push them toward the late memory stage that we think actually can be disinhibited by these checkpoint inhibitors. So that immune remodeling in the post-transplant setting is exciting. So what Philippe did was basically give a group of patients pidilizumab in that setting. And I think that there are a couple of relevant things. So 50% of those patients had some measurable disease even after transplant. And in those patients, the response is actually a third of the patients who were treated with pidilizumab post-transplant actually converted to a CR, and 50% had responses in those patients. And again, despite the fact that many patients had measurable disease at the time of transplant, the responses were good. Now, this was not a randomized controlled trial, so there was no control group that was treated without pidilizumab. They looked at historical controls, but at least with respect to historical controls, response rates appeared to be favorable. And again, there was this conversion that we wouldn't, at least intellectually, expect between patients who had measurable disease to unmeasurable disease.
Well, there's also the patients that, the good third of the patients that went on this trial were PET positive going into the transplant, and that's a group that historically we think very bad outcomes. You have the 70% survival at 16 months.
This was a high-risk population, and then this is a small number of patients, but the signal is really there. And based on some of this data and others, we actually initiated a study in our center post-auto transplant in a high-risk patient, relapsed within a year for large cell lymphoma, primary failures obviously as well. And then we give them EP and Nivo combination post-auto, obviously in a dose escalation fashion because we have to be careful at the beginning. To your point, this is a perfect immunological milieu post-transplant when you try to do an immunotherapy, reset the clock because you might have less of this immunosuppression that is induced by the clone. So I think this is really exciting as we can revisit and reinvent auto transplant.
And that group of patients that you just talked about that has a relapse within 1 year of transplant, we know does very poorly, and I think that's an ideal place to test these concepts.